Okay, we're on to chapter 9. This is the last chapter to cover for test 2, or just, I guess, the grouping for test 2. And the, um, the concept is we've been talking for 3 chapters, or actually 3 chapters about bones, now to talk about what happens when bones come together. As I started out referring to the fact that bones actually work with muscles to create movement. It's one of their jobs, and articulations is the topic of talking about joints and talking about their structural, their functional makeup, and also their structural and functional capacities and how we classify them and define them. So articulations, joints, both interchangeable words. It's where two bones connect. And so that's it. You can have two bones. If you have something else come in, that's a different articulation. And this is where there is the possibility of movement. I guess I have to backtrack that a little bit because there are articulations or joints where there is considered no movement. But please understand that they didn't start out that way. In the infant, most likely, I'm trying to rack my brain to see if there's an exception to this rule, but most likely there was a space between and those bones remodeled into a butting up of bones next to each other, so there was no movement. Joint structure, so the actual makeup of the joint, how the bones get together, what kind of connective tissue is attaching the bones one to the other, is going to determine what kind of movement is made, so the direction, and how extreme the movement is, so the distance of the movement, or we consider it range of motion. And those of you who are going forward in say physical therapy, or going to go forward in any kind of hands-on type medicine, range of motion becomes very important. And even if you are looking at that aspect of your patient to see diminished energy, diminished movement, or where pain shows up, range of motion becomes important. And then also just a factoid, I guess. I don't like that word, but I used it anyway, factoid. Strength decreases with mobility. So the more mobility you have with a joint, the more subject it is to injury. So strength decreases with mobility. It doesn't mean that your joints are weak where they're mobile. It's just they're more vulnerable to injury where they're mobile. Two methods of classification of joints, just generally to start getting information in your head. You have functional classification, which is based on the distance of movement or the range of motion of the joint. So how much movement that joint can make and what kind of movement that is. And then structural, which is what kind of tissue is holding those bones together, and even what is the design of the ends of the ends of the bones where they actually are coming together. So that's why anatomical organization of the joint. But generally what you're thinking of is the connective tissue allowing movement or not? And are the way the two bones articulate with each other defining what kind of movement you might have? You might think back to when I talked about the ulna and the humerus, and I referred to the head of the ulna and then the notch, that olecranon fossa. And you had the head of the ulna had that notch in it that fit right into that fossa, and you could see where that would create the hinge movement that we think of as the elbow. And that is the structural design of that joint is not only determined by the ligaments that hold those bones together, but also by the design of the end of the long bone. Types of functional classifications are synarthrosis. Those are what we consider immovable joints. Amphiarthrosis, slightly movable, and diarthrosis, which are freely movable. And most of the joints you study and learn about are going to be diarthritic joints because they're the ones with the most problems. They're freely movable, freely open to having problems. So think of your hip, your knee, your shoulder, your finger joints, your toe joints, the ankle. All of these are diarthritic joints, and all of these are joints that yet I'm sure you know 5 or 6 people who probably have problems with them. Or not, hopefully not, but I certainly know many. And then structural classifications generally are fibrous, whether you have fibrous connections, cartilaginous connections, and then synovial. And we'll look at a few different joints and where you find them. So the synarthritic joints are the ones with no movement. And with those, the most common are sutures. Sutures where you have the 2 bones of the skull. The line is pointing to the sagittal suture where the 2 parietal bones come together. They didn't start out that way. Think of the little infant and how you have the soft spots or the fontanelles, but those bones become remodeled until they butt up against each other, and then there's a fibrous connective tissue that is very thin but dense fibrous connective tissue that bounds those 2 bones together, allows for little movement. Then you have gomphosis. Those are the types of connection between teeth and the mandible and the maxillary bones. Then you have synchondrosis, and that one is, you find that between the manubrium of the sternum and the first rib, where there is a cartilaginous type material and a little bit more movement than a suture, but not really any more movement there. And then you had syncytosis, and that is where 2 bones started out as separated and basically grew together to the point where you can't even see where they were separated. So these are immovable joints, synarthritic joints. The one that is probably the most commonly known is the suture, and sometimes the gomphosis, the joint where the tooth embeds into the bone of the jaw. Amphiarthritic joints are syndesmosis, and that would be the end of the tibia and fibula where you have this ligamentous type connection. You have a little bit of movement, and actually the more you could say it's a little give. There's a little give there. So thinking of it as movement is maybe a bit of a exaggeration. It just is not, if it were totally static, you wouldn't have the balance that is necessary, and you'd also probably actually injure something if it was totally static. And the symphysis, which is where the 2 pubic bones come together, so many times it's called the pubic symphysis. You do have a wedge of fibrocartilage, and this one is very important and probably very misunderstood or very mis-talked about. It actually has, you have slight movement in this joint every time you take a step, and if you don't have that slight movement, you can have incredible pain, or if the movement is if the 2 pubic bones are too far away from each other, even by millimeters, you have the inability to walk and also the inability to walk without pain. This happens sometimes in childbirth, where if a woman is in labor too long, this actually can separate. And then it sometimes happens if with football players, if they have too many groin injuries, where you have, and we're talking about a millimeter too far either way, where you have possible dysfunction, the person isn't walking, but you definitely have pain. And then you have your diarthritic joints, which are most of them. So anything that really anything that we didn't just talk about is a diarthritic joint. These are joints that have synovial, that have joint capsules, synovial membranes, wider range of motion, usually at the ends of long bones. And they tend to create movement in several types of axial planes: monaxial, biaxial, and triaxial. Monaxial, you can think of elbow, ankle; biaxial, wrist and ribs; and triaxial, shoulder and hip. And what they're talking about, that there are the planes of movement. And of course, these pictures come from your textbook. Speaking of synovial joints or diarthritic joints, they have some key players because of that capacity for a wide range of motion. The bones are actually not moving against each other, but they can rub against each other. So what you have at the ends of long bones are articular cartilage, and these are pads of cartilage that has no vascularization. So since there's no vascularization, there's no pain sensitivity. And you also have the joint enclosed. This is a sagittal section, and you can see the joint capsule. That's actually enclosing the entire joint all the way around. So you have basically a space between that pink space that you have on here is actually a space that is walled off from the outside world. And what that does is that allows that synovial fluid to be in that joint space to reduce friction, because synovial fluid is made of proteoglycans, so protein glucose type compounds that are secreted by fibroblasts that work to reduce friction. So you can think of it as kind of the oil that's in the joint. So these proteoglycan secreted by the fibroblasts, which is a component of synovial fluid, not the only thing in synovial fluid, is like the oil that lubricates this joint. Function of synovial fluid, as I said, lubrication. Also to bring nutrients to the articular cartilage, and also to reduce shock and absorb shock, as well as the articular cartilage. Factors that stabilize the joint are and prevent it from overextending its range of motion is that joint capsule. And so you have somebody who is maybe double jointed, or if you overextend a joint, particularly this sometimes happens on young kids, you actually injure the joint. Sometimes it's not injured without being able to be repaired, but it's definitely injured. And the joint capsule is made up of fibrous collagen fibers, and we know from previous chapters that they are extremely strong collagen fibers. And you also have this cartilaginous type tissue called meniscus, which helps protect the joint, as well as other bones which may restrict movement, muscles which will only contract and pull the bone to a certain degree, as well as fat pads, tendons, and other tissue that may get in the way of increasing range of motion. So there are a few things that keep the joint from overperforming, I guess, in range of motion, and potentially injuring it because of that. Here's a nice, this is a pretty standard picture. It's probably, this is where we're going to pick it up on the next one because we're running out of time. So we'll talk about these accessory structures next time.